everyone. This is Dr. Kamal, and we have another video today, and it's about shock. I chose this topic specifically because it can be very confusing to medical students and providers. Um, is I've heard before some people call hypoglycemic shock, but actually, does hypoglycemia cause a shock? Or if someone having an infection or having sepsis, does this automatically translate into septic shock? So, shock, if we'll start right away, so shock, it's all about oxygen. So, when you have decrease in the tissue perfusion, this decrease the oxygen supply to the tissue, and the oxygen is the main factor for the aerobic metabolism. If you don't have oxygen, you won't be able to do the aerobic metabolism. So the cell will switch to anaerobic metabolism. And that's when you see the increase in the lactate that we see in different types of shock, which is indicative of tissue hypoperfusion. And the main thing, the aerobic metabolism is important to the cells is ATP production. So when you have decrease in the tissue perfusion, you have decrease in the oxygen supply. That's when the cells start having backup plan or an emergency plan, which is anaerobic to be able to get ATP. But this ATP, it's way less than the aerobic metabolism, right? So shock, it's all about oxygen. So let's just review very few points about oxygen and different definitions, because this can be confusing. We have the oxygen in our body in two forms. The first is bound form, which is bound to the hemoglobin inside the RBCs. So each hemoglobin actually it binds to four molecules of oxygen. And that's actually 99% of the oxygen in our body, it's bound to the hemoglobin. There is 1% or 2% which is free oxygen dissolved in the bloodstream. So those are the two forms of oxygen in our body. So if we start with the SaO2 versus SvO2, SO2, it's the saturation of oxygen in the artery. And to be able to get that, you need an ABG. So this actually measures how much oxygen is bound to the hemoglobin, right? Versus the SvO2, it's the oxygen saturation, again, the oxygen that's bound to the hemoglobin, but in the vein. And you have to get this from central venous axis to be able to indicate the actual oxygenation of these veins. Then we have CaO2 and CvO2, which is the total oxygen content in the artery or the vein. For CO2 is the total oxygen content in the artery, CvO2 total oxygen content in the vein. So why this is different than the SaO2 and SbO2? Because this includes the oxygen that's dissolved in the bloodstream, which comes to another two definitions, which is PaO2, which is capital A, and that's mainly the oxygen pressure in the alveoli, and P small o2, that's the oxygen pressure in the artery. So the total oxygen content between the bound oxygen to the hemoglobin, and on the other side, the free oxygen in the bloodstream. So when we talk about shock, we talk about decreased tissue perfusion, but it's not just about perfusion. So let's look at this. This is the heart, and we have blood vessels going to the tissue, right? So there has to be two things done. First, able to deliver the oxygen to the tissue, and for the tissue to extract this oxygen. So perfusion is not just about the delivery, it's also about the tissue extraction. So oxygen delivery, it's mainly a system issue, and oxygen extraction is mainly a tissue issue, right? So let's talk about oxygen delivery, right? Oxygen delivery, DO, stands for oxygen delivery. It's cardiac output and CaO2. So simply, how much blood are you giving to the tissue and how much actual oxygen in this blood? So the blood you are giving to the tissue, that's the cardiac output, which we measure how many liters of blood per minute. And on the other side, CaO2 is the actual oxygen content that's delivered to the tissue. And we just said the oxygen content in our body is in two forms. One, which is bound to the hemoglobin, and the other that's free oxygen in the bloodstream, which is very, very small factor, 1 or 2% of the oxygen in our body or in our blood. So this is an equation for CaO2 which is 1.34 multiply hemoglobin multiply SiO2. So this part of the equation, it represents the actual oxygen that's bound to the hemoglobin. So you need the hemoglobin number, 7, 8, 9, 10, whatever the number is, and the actual SiO2. So that's the first part. And the second part, plus 0.03 multiply PaO2, which is the dissolved oxygen in the body, which is very small factor. So the actual equation here, 0.03, so this anything multiplies 0 equals 0. So you can just disregard this second part of the equation. And if you want to know the actual oxygen that's get delivered, you need to calculate 1.34 multiply the hemoglobin multiply how much oxygen bound to the hemoglobin, which is the SO2. The second part of the equation is the cardiac output, right? So the cardiac output, it has different equations that you can calculate the cardiac output. So let's start with the first one. So the first one, it says cardiac output equals oxygen saturation over CaO2 minus SvO2. Again, the total oxygen content in the artery minus the total oxygen content in the vein. And this is actually derived from another equation which says oxygen consumption, if you want to know how much oxygen the tissue has consumed. So this has to be cardiac output multiply CaO2 minus SvO2. And it kind of makes sense. If you want to know how much the tissue got actual oxygenation, you calculate how much oxygen was in from the artery and how much oxygen out from the tissue, which is the vein representation of the oxygen, right? And multiply that, multiply cardiac output. So this is the first equation. The second equation, it's MAP over SVR. So cardiac output equal MAP over SVR. Why MAP? Why not diastolic or systolic blood pressure? Because actually MAP represents the arterial venule pressure, which is the pressure at the very end of the circulation that actually is the side of the at the side of the capillaries with where the actual tissue extract the oxygen, right? So the more MAP you have, the more cardiac output you have over SVR, which is the systemic vascular resistance. And this kind of makes sense. If you have a lot of systemic vascular resistance, you have a lot of pressure to push against, which is the heart, and this decrease the cardiac output, right? The third equation, which I think is more the most important, which is stroke volume multiply heart rate. If you want to know how much cardiac output you are getting, it will be the stroke volume, the actual blood that's coming out of the heart, multiply heart rate, which makes sense again because the cardiac output is how many liters per minute. So the liter part is the stroke volume, the minute part is the heart rate. And if you want to increase the stroke volume, you need to increase the preload, which is the end volume that's the systole gonna push, and increase the contractility of the heart muscle, and also decrease the afterload, which is consistent with the reciprocal effect of the systemic vascular resistance, right? So this part, the first part of the perfusion is about oxygen delivery. The second part of the perfusion, it's about oxygen extraction, which happens at the tissue end. And there is an equation. So actually, oxygen extraction usually it's only 25 to 30%. If you are giving the tissue a lot of oxygen, 100% oxygen, the tissue doesn't take it all because there's other organs need this oxygen. So you still need some oxygen to stay in the system. So the tissue doesn't extract all the oxygen, it just extract 25 to 30% of it. And oxygen extraction, we can calculate it. We don't have like very accurate measurement for the oxygen extraction, but it usually depends on two things, the oxygen consumption and oxygen delivery, which makes sense. If you are consuming a lot of oxygen, you will need to extract more oxygen, right? For example, when you have when the tissue consume a lot of oxygen, when there is increased metabolic needs, like exercise, fever, sepsis, any kind of stress on the body. And the mechanism it does this, we know all these different factors can increase the temperature, can increase the hydrogen ion, which can be, in the form of lactate, and this also will increase carbon dioxide. So all these different factors, if you remember physiology and the oxygen dissociation curve, so all these different factors do right shift to the oxygen curve, so it increase the oxygen unloading to give more oxygen to the tissue. The other factor that plays a role in the oxygen consumption is the oxygen delivery, which is a reciprocal effect. So if you are giving the tissue or the tissue has access to a lot of oxygen, it will not take a lot of oxygen, which is demand supply issue. If you are, go to Walmart every single time, you have like rice available all the time. You'll just take one and leave. But if you go multiple times and you don't find any like rice on the shelf, you will take next time you go and you find rice, you will take all the rice you can find. So if you are increasing the delivery, this will decrease the extraction. So increase the delivery of oxygen will decrease the tissue extraction. Other factors, those are the big factors. Other factors could be mitochondrial dysfunction, because remember the aerobic metabolism needs the mitochondria to um, if you remember Krebs cycle, some of it happens in like with the help of the mitochondria. So you need actually the mitochondria here. That's why some poisoning, like cyanide poisoning, can affect the mitochondria, which can affect the tissue oxygen usage. Then also remember about the AV pressure, the arterial venule pressure, which can be depending on the map. So the higher map or the adequate, if you have adequate pressure at the end, at the capillary end, you can extract oxygen. So again, this is just an example. You have here the heart, and you have an artery going to the tissue, and there is a vein coming out of the tissue. So perfusion is two steps. First, to deliver the oxygen. Second, to extract the oxygen. To deliver the oxygen, you need the vessels, the heart, the system, the cardiovascular system. To extract the oxygen, that's more tissue problem, right? Then you have the artery and you have the vein, and there's oxygen in the artery and there's oxygen in the vein. Most of the oxygen is bound to the hemoglobin in the RBCs, and how we measure the saturation of oxygen in the artery. It's SaO2, and for SaO2 you need an ABG, you need an arterial sample. On the other side, the vein here, it also has oxygen, less oxygen, yes, but it has oxygen, and this oxygen is bound to the hemoglobin again. And to measure this saturation of oxygen in the vein, it will be the SVO2. And the SVO2 can be a marker of shock, which we'll talk about in a little bit. So the SVO2 normal range is usually between 65 to 75. Remember, we just said oxygen extraction. Whenever there is oxygen supply to the tissue, the tissue doesn't extract all the oxygen, just extract 25 or 30% of the oxygen that's coming, and only leave the rest. So you have oxygen in the vein is VO2 about 65 to 75, right? So let's imagine those three different scenarios, okay? The first scenario, we have the artery, we have the tissue, and we have the vein. So the artery, to measure the oxygen saturation in the artery, will measure the SO2, which let's say it's 100%, right? Which means, for example, that's just for demonstration, that each hemoglobin is bound to 4 molecules of oxygen. This oxygen in, or this hemoglobin in the artery, goes to the tissue. The tissue extract part of it, and you look on the other side here, and you check the hemoglobin saturation or the oxygen saturation in the vein, which is the SVO2, and you find it's just 75%, which means the tissue extracted 25%. So the SO2 100%, the tissue extracted 25, then what's left over, the SVO2, which is 75%, which is in the normal range. Let's see what happens in the shock state. Let's say the same scenario, you have SO2 of 100, right? So you have a hemoglobin that's bound to 4 oxygen, right? And you look at the venous side and you find the SVO2 is 50%. So the SVO2, 50%, that's low SVO2. That means the tissue extracted more oxygen. So instead of the tissue extracting 25%, now it extracted 50%. Remember, to increase the extraction. If you decrease the delivery, you will increase the extraction, right? So in this example, number two, that means there is a delivery issue. There is a delivery issue. That's why there is higher tissue extraction. That's why you have lower SVO2. And we'll talk about when like the delivery kind of shocks later. Number three, example number three, again, you have artery with ACO2 100%. You look on the other side, you found SVO2 of 100%. This means the SVO2 is high, right? That means the tissue extraction was almost zero. The tissue didn't extract any oxygen because you have an artery with ACO2 100, and in the other side, you have the vein with oxygen saturation 100 as well. So this means the tissue is not able to extract. So this means there's an extraction problem, which you can see in different states, like mitochondrial dysfunction or sometimes early sepsis. Most of the types of the shock are gonna go under this category, which is cardiogenic or obstructive or, late sepsis. So most types of shock will be delivery issue rather than extraction issue, right? So let's talk now about the different types of shock. Different types of shock, again, we are talking here about the heart. We have the heart, we have blood vessel going to the tissue. Shock means tissue hypoperfusion. You are not able to deliver the oxygen to the tissue, or the tissue is not able to extract the oxygen, right? So we have four different types of shock. So let's start one by one. First time is the hypovolemic shock, which is mainly you have decrease in the volume of the blood that's going to the tissue. So here, number one, you have low volume here inside the vessel, so you are not perfusing the tissue. When do you see this? Basically, it's either decrease input or increase output. Decrease input, like cases of severe dehydration, cases of severe diarrhea or burns, even that comes with severe dehydration, or increase the output, like hemorrhage, which can be external, like someone in accident or whatever, and they're bleeding everywhere, or it can be external, like retroperitoneal, GI, or any kind of like big volume hemorrhage. So the hypovolemic shock, you mainly have decrease in the volume, which decrease the preload, right? Because again, remember this equation, we have the cardiac output equals stroke volume multiply heart rate, and for stroke volume, you need preload. So if you have a problem in preload, you have a problem in the stroke volume, and you have a problem in the cardiac output, right? So here, the cardiac output will be decreased in the hypovolemic shock. We'll talk about this, but when you have decrease in the cardiac output, the sympathetic system will get activated. So the sympathetic system gonna stimulate the alpha 1 receptor, causing vasoconstriction. So as a reflex, you will have increase in the systemic vascular resistance to try to compensate for that, right? Then the third thing is the PCWP, which is the pulmonary capillary wedge pressure, which if you look at this, you have the two lungs, pulmonary veins, and goes to the left side of the heart. So actually, the pulmonary capillary wedge pressure is reflective to the volume status or the pressure in the left side of the heart. So here's again, you have low volume, so you have decrease in the post or papillary capillary wedge pressure, which is the opposite of like when we'll talk about cardiogenic shock. There is volume overload and there is backup outflow to the lungs and congestion in the vein. So you'll find the PCWP is high, which we'll talk about in a little bit. Then let's talk about the SVO2. The SVO2 in the hypovolemic shock, it's not an extraction problem, it's mainly a delivery problem. And if you have a delivery problem, the SVO2 will be low. And remember, the SVO2, you ideally you get it from a palm cath to look at the pulmonary sample or like vein sample. But if you don't have that, you can get central axis, which like PIC or central line. There might be maybe like 1 or 2 or 3 points different, but at least you have to get it from a central axis, not a midline, not a peripheral IV. So this is the first type of shock, right? The hypovolemic. The second type of shock, which is the cardiogenic shock, which is a pump problem. Someone is having MI, someone who is having decompensated heart failure, their heart muscle is not working, right? So here is the cardiogenic shock. You have a problem in the pump, right? So if you have a problem in the pump, you have decrease in the contractility. And again, you need good contractility for a good stroke volume and cardiac output. So here you have decrease in the contractility, decrease in the stroke volume, decrease in the cardiac output, right? So you have decrease in the cardiac output. What happens when you have decrease in the cardiac output? There's some compensation from the sympathetic system which cause increase in the systemic vascular resistance. We have increase in the systemic vascular resistance as a reflex. In the cardiogenic shock, what happens is if the heart is not able to push all this blood to the circulation, it kind of stays in the heart, then backflow to the lungs and the pulmonary circulation. So the end or the pulmonary capillary wedge pressure, the very end pressure at the level of the lung, which reflects the left side of the heart, will be high. Then when it comes to the SVO2, okay, again, it's a delivery problem. So you have SVO2 low. The third type of shock, which is the obstructive shock, and I put the obstructive shock and cardiogenic shock in same color because they have different mechanism, but they have very similar factors or like you know the cardiac output SVR, PCWP, SVO2, very similar between these two. So when you have obstructive shock, it's mainly outflow. There's something preventing the oxygen to be going smoothly through the system. So you can have some kind of block, which is pulmonary embolism scenario. So you actually here, number three, if you look, you have actual blockage in the system with the pulmonary embolism, right? And remember the pulmonary circulation and the systemic circulation, it's all connected. So if you have increased pressure at some point, it just will reflect to the different types, different parts of the circulation. Then the other part is its increase in the backflow pressure, which you can see in the tension, pneumothorax, or cardiac tamponade. So those are the different pathologies that can cause obstructive shock. And in the obstructive shock, you have increase in the afterload because you are pushing against higher pressure, whether you have PE, tamponade, all these different scenarios, you have increase in the afterload. But also you have decrease in the preload because let's just imagine tamponade is the easiest to imagine. If you have a lot of fluid around the heart, compressing the heart, it will prevent the relaxation of the heart and the filling of the heart. So you'll have decreased preload. So you have here good volume in the system, which is the opposite to the hypovolemic shock. The hypovolemic shock, you don't have enough volume. Here you have enough volume, but the heart itself is not able to fill or get all this volume to be able to um, get it out of the heart for the circulation. So again, in that scenario, you have decrease in the cardiac output, and here you have increase in the SVR, which is reflex, but also obstruction. If you have physical obstruction in the circulation, you will have backup pressure, right? And again, the PCWP will be high. And again, here's a delivery problem, so the SV2 will be low. Then when it comes to the fourth type of shock, which is the distributive shock, which comes in different flavors. You have the anaphylactic shock, the septic shock, and neurogenic shock. Neurogenic, I have a little star here because it's a little bit different. We'll talk about it. So in the distributive shock, you have severe vasodilations. So in case of the anaphylaxis, you have the mast cells and the histamine and all the different cytokines, all these different chemicals and inflammatory marker that's causing vasodilation, which is very similar scenario in the sepsis. You have a lot of cytokines and a lot of inflammatory um, marker that's causing vasodilation. So what happens when you do the vasodilation? You will decrease the systemic vascular resistance. So you'll have very dilated arteries and veins, and instead of this volume inside the veins going to the heart, it will stay in the vessels, or sometimes in sepsis, it will go to the third spaces. End result, you have decrease in the preload, right? So actually, in this case, you'll have increase in the cardiac output. Why? Here's the thing. We talked about different equations for cardiac output, and we said cardiac output equals MAP over SVR. So in this scenario, you have decrease in the SVR. So in order to compensate, the heart will increase the contractility, will try to increase the afterload, will try to increase the heart rate to increase the cardiac output, right? So if you have decrease in the SVR, you'll have increase in the cardiac output. Neurogenic shock is different. Why? Because neurogenic, you have problem in the nerves, including the sympathetic nerves. So you are not able to stimulate the alpha receptor, you are not able to stimulate the beta receptor, nothing, right? So you cannot increase the heart rate, you cannot increase the contractility. So that's why in all distributive shock, you will see increase in the cardiac output, except the neurogenic shock, because actually the sympathetic system has a problem to act on the alpha receptor and the beta receptor. So here we have the increase in the cardiac output. Let's talk about the systemic vascular resistance, which is the main issue. It's not a reflex here, that the main problem for the shock, which is the decrease in the systemic vascular resistance. And again, you don't have backup volume or congestion, so you will have decreased in the PCWP. Here's the thing, in sepsis and anaphylaxis, sometimes you have extraction problem. So you can have increase in the SVO2. So all these different types of shock are mainly delivery kind of shocks. The body is not able to deliver the oxygen to the tissue. But here, in there's always there will be still some delivery problem in this kind of shock, but also you'll have extraction problem. That's why the SVO2 will be high. So the next thing I want to talk about before ending this discussion is shock progression. We talked a little bit about compensation, and when the cardiac output drops, the heart or the sympathetic system try to compensate, so it get activated and increase the systemic vascular resistance and all that. So actually, shock is kind of stages. So you have compensated, decompensated, and eventually, if you don't treat the decompensated part, it will switch to or end up in cell death, which is irreversible. So the compensated, what happens here, you have decreased delivery to the tissue, right? So number one, we talked about this equation, which is the extraction. If you have decrease in the delivery, you will increase the extraction, right? So if you have decrease in the delivery, the extraction of the tissue will increase. And also, if you are not perfusing and you have low volume, this will stimulate the renin-angiotensin system, will stimulate the V1 receptor in the vessels, and will stimulate the sympathetic system. When you stimulate the sympathetic system, it will work on the alpha receptor and beta receptor, beta 1. When it works on alpha receptor, it will cause vasoconstriction to increase the SVR. When it works on beta 1, it will increase the contractility of the heart. And remember again, the cardiac output equals stroke volume multiply heart rate. So here you are increasing the contractility and also the heart rate. On the other side, it will stimulate V1, which is the ADH receptor, so this will increase the ADH. And what does the ADH do? It increases water reabsorption in the kidney. But also, it will stimulate the RAS system, so you have increase in the aldosterone, which will increase the sodium reabsorption in the kidney level. So here you increase the water reabsorption and you increase the sodium reabsorption, both together will increase the preload. So this is the compensation, right? Compensation in terms of the tone, right? And compensation in the terms of the volume. You are trying to increase the volume and increase the tone. But also at the level of the pump, at the level of the heart, you are increasing the contractility and you are increasing the heart rate. And remember again, this equation, if you have decrease in the cardiac output, you are trying to increase the heart rate and try to compensate. If when compensation fail, it becomes decompensated shock, which is failed compensation to simplify it. And this happen if you have prolonged shock, if you have severe shock, if you have multifactorial shock. A lot of patients can have like PE causing cardiogenic shock or right heart failure, and they also have sepsis and they have volume overload. So you can have different types of shock at the same time. So this will decrease, and at the decompensation stage, you will have decrease in the blood pressure and you will have decrease in the perfusion. When you have decrease in the blood pressure, it doesn't automatically translate to decreased perfusion. You have to evaluate perfusion separately. How to evaluate perfusion? Usually, the two things I look for are alter mental status and decrease urinary output. The normal urinary output is zero point 0.5 cc per hour per kilogram. So early signs of decrease in the perfusion, the mentation of the patient will change, but also the urinary output will drop. So this is in summary the pathophysiology of shock, how shock happens, what can lead to decrease the perfusion, the different types of shock, and some kind of like summary for the shock progression between compensated, decompensated, and cell death. I hope this video was beneficial to all of you guys, and thank you for watching the video.